So by popular demand, the Hawaii State Rural Health Association is delaying their annual meeting until after we talk about Project ECHO. Because Project ECHO is brought to you by the Hawaii State Rural Health Association. And it is our biggest initiative this year, and we're very excited about it. So we are very, very, very excited to tell you about what we learned by going to New Mexico and hearing how they do it at the Mecca, Echo Mecca. And we have 3 expert speakers who were there in person and have different insights and contributions to the project. So let me introduce these 3. They're going to manage their slideshow. You don't have a clicker, but themselves. Okay, so this is Deb Birkmeyer-Peters. She is co-director of the Pacific Basin Telehealth Resource Center, an expert in getting people together and sharing information. And she's, I would say, the techie part. Dr. Dan Saltman, oh, she gave me the evil eye, maybe not that techie.
I'm learning about things that I never knew I was.
She's the techie learning part. Dr. Dan Saltman is an internist at Waikiki Health Center who has, out of necessity, done a lot of hepatitis C care for the patients of Waikiki Health Center and benefited from Project ECHO to learn the skills needed. And Ann Chipchase is a community advocate, and she works for Ohana Health Plan now, but lots of experience in the marketing world. Okay, those were pretty bad introductions. I apologize, guys, but at least they're my friends, so they will forgive me. So let me give them their lays, and you can start. Go get them.
Like I said, I always learn something from Kelly. Actually, I've got her fooled. I learned a long time ago that you don't really have to know something yourself. You just have to know who to ask. Okay, so in terms of technology, I am the go-to person because I know the people to ask the technology questions of. And anyhow, my role in this today, okay, and what I was elected, selected, or drafted to do, okay, was to present an overview to you of Project ECHO. If you saw the video earlier today of Dr. Sanjeev, he conceptualized this whole Project ECHO as being something that could be done, okay, to help the patients in rural New Mexico. He had a hepatitis C clinic. As he mentioned, his patients were traveling 200 to 250 miles each way to come to his clinic. And often because of the distance, what would happen is that his patients would show up when they were way more advanced in disease. So what he thought was, wouldn't it be better if, in fact, you could take what I know about the treatment of hepatitis C and share that knowledge about the treatment of hep C, okay, with the primary care providers in the communities where the patients live. And it was the kind of thing that a lot of people think at first when they look at this, and this will be repeated because it is something that comes up a lot. This is not telemedicine. I mean, if in fact Dr. Sanjeev were to do a consultation with a patient remotely through telemedicine, okay, or through some kind of VTC connection, he would be treating one patient. His idea is that he would like to take the knowledge that he had gained, okay, about this, and to share that with the providers in the communities, okay. So with that then, with that as a little bit of background, I will proceed with a little bit more details about what this is. ECHO stands for Extension for Community Health Outcomes, and basically one of the mantras, okay, of the New Mexico group, the Mecca, as Kelly referred to it, is you move knowledge instead of patients, and that's just keep that kind of thing in mind. The mission of ECHO is to democratize medical knowledge and to get best practice care to underserved people all over the world. Okay. The goal of Project ECHO, meaning the corporate Project ECHO, meaning all of the Project ECHOs around the world, is to touch the lives of 1 billion people by 2025. The goals are to expand the capacity to provide best practice care for common and complex diseases in rural and underserved areas and to monitor the outcomes. Okay, and I've sort of like, you see the recurrent themes here. What this whole project is capacity building, okay? It's not just a matter of treating a patient or a limited number of patients. It's the whole idea is to build capacity in the communities to have these patients with common but complex diseases and to have providers that are in those communities. It's also been a theme throughout this conference. So what this is doing, okay, is expanding the ability to treat these patients without gaining more specialists. We've heard throughout the conference that you aren't going to get a whole lot more specialists in a reasonable amount of time. So one of the options is to see if you can't build capacity out in the communities with the existing resources that are out there. The model of Project ECHO is to use telehealth technology, okay, telecommunications technologies, if you will, to leverage scarce health care resources, to share best practices and to reduce variation in care, and to improve outcomes through practice-based learning that develops specialty expertise among primary care providers and monitor outcomes. Now, there's a little bit of variation in some of those things in terms of practice, and I will get to that later. Essentially, if you look at a typical ECHO model, you have a hub and spoke, and all of a sudden, when you start talking hub and spoke, all of the people always are thinking, oh, it's a telemedicine network. Well, not exactly. What you have is a hub, okay, at which you will have your specialists. You will have a specialist in a particular specialty. You can also have on this team that is located at the large hub other professionals, okay, other healthcare providers that would have something relevant to say to the particular cases that are being considered. In some of the teams, you have pharmacists, you have behavioral health providers, psychiatrists, psychologists, you can have social workers, okay, that are all part of this specialty team that can all contribute, okay, as to how they would approach the treatment of a particular disease state. Located in the remote sites, okay, are the spokes. These are the places where the participants, these are where the primary care providers, okay, are located. And this is what, basically this is it. They all communicate, okay, over a VTC. Currently, the platform that's being used is Zoom, okay, which is really, really easy to use. I mean, we use them for all of our meetings now. It's secure, it's encrypted, there's all kinds of rules that go along with this. You cannot present any kind of personal health information. And essentially what happens is in a typical tele-echo clinic, a clinic is usually formed around some particular specialty, okay, such as endocrinology, or a particular disease state, such as hepatitis C. And what happens is that in an 1.5 to 2 hour clinic, the participants at the spoke sites, okay, are listening at first to a short, usually like about a 15-minute didactic, presented by one of the specialists at the hub. After they've listened to the didactic, 1 or 2 or 3 of the participants of the spoke sites present a case study that they have in their particular practice. Prior to doing this, there's all kinds of information, okay, that is sent to the hub site so that the hub site, all of the specialists in the team, okay, have the information that is available to them so that this thing moves very, very smoothly. The hub specialists then mentor, okay, the participants. They give them the kinds of information, they make recommendations as to what they would do in terms of treating this particular case, and then they are left, the participants are left to take that information and to treat it, okay? Let's see. I think that pretty much sums it up. There are something like 55 clinics, okay, that some of them are duplicates in terms of the specialty or the disease state that they treat. They're in 10 different countries, but these occur during a 12-week session, okay, and during the 12-week session, once a week they meet for an 1.5 to 2 hours, and CME, free CME okay, is issued for participants who take part in this. Again, the whole idea is that the knowledge that the participants gain, okay, is what is really the major goal here, okay? It's not the treatment of any particular case, although that does, of course, help. But it's the idea that these participants can then go forward in the future and they can treat similar cases as well. And also, because it's a network, the participants at all of the spokes are hearing the cases of their other fellow participants, and they are learning from those as well. Now, these are just a couple of pictures that are put together. What you're seeing is a photograph, okay, of a hub site, that's the large photo, and then all of the various spoke sites that are participating in this particular clinic. This again is this is a photo that is being shown in at the hub site, showing the hub team viewing the participant sites on the screen there, the various things. The one thing again, and that again I said, I know this is redundant, ECHO is not telemedicine. And I think that this picture kind of summarizes that very well. You have the ECHO clinic. What happens is it supports the community-based care teams, and that the patients that it reaches are much greater than what you have in a telemedicine model, which is traditional, where you have one specialist who is consulting with one patient. And again, this is something that they stressed in New Mexico repeatedly. It's not simply a patient care clinic. Even though case studies are presented, the whole goal here is to teach and to mentor. It is educational and not consultative. You build expertise at the primary care level so that these common but complex cases can be managed. The clinics are all different, and they're based on the disease focus and the style of the teams involved. What has happened over time is although it was originally intended for primary care providers, primarily physicians, okay, at the remote sites, over time some of these clinics have evolved. I listened to a presentation about a tele-echo clinic that's at the University of Washington. It's for MS, and the neurologists that were at the hub site, the ones that specialized in MS, initially thought that what they would be doing is that they would be having primary care providers, okay, at the remote sites. But it turned out that in practice, this was even too complex for the primary care providers. But the people who were interested, the participants who were interested, were community neurologists. So you actually have the subspecialists that are sitting at the hub, and then you have the specialists who are treating the MS. But again, what it's doing is it's taking this specialty knowledge and it is pushing it out into the communities where the patients can remain and can be treated. All right. Now, Kelly did say that I was the technologist, right? I don't know that this is going to work. There's supposed to be a video that's embedded in this, and I do not see it. You see it? No. It's not there.
It's not there.
It is
Okay.
not there. Sorry.
Let's skip it.
We'll skip it. You've seen enough videos for today. Anyhow. No. No, it's down here. Okay, so sorry about that, but anyhow, what we will do is that in the handouts that when the slides are published, we will put, it's a YouTube video, okay, so what we can do is we can put the link for the YouTube video and you can watch it. It's actually fairly interesting because it's of an echo clinic that is actually occurring here in Hawaii, but it's done by the military, okay, and it's between Tripler and Schofield Barracks, and it's on pain management. And so here comes Peter. Here comes the link guy.
Yep.
Sorry about that. See, I told you. I know the people to ask.
Looking strong, looking strong. 340, keep it moving.
The U.S. Army is taking a new approach to its battle against an old foe, pain.
How long are we stretching for?
And the military is enlisting the help of the University of New Mexico Health Sciences Center to help fight it.
There's a huge problem in this country, huge burden of chronic pain that affect not only the civilian sector but also the military sector.
I just got the sheer pain going through my back and my legs.
To tackle the problem, the Army is embracing a more integrated, multidisciplinary, and holistic approach to pain care, one that includes not only medications and the latest in interventional procedures, but non-traditional therapies such as massage, acupuncture, biofeedback, and yoga.
Down, hug your toes, find downward facing dog.
But spreading the word on this new approach to pain management and improving the coordination of pain care across a large, complex organization like the U.S. Army Medical Command is a huge challenge. That's where the University of New Mexico and Project ECHO come in.
Brad, how do you feel about that? That seeing him for
The primary purpose of Project ECHO is something what we call force multiplier. That is, the goal is to dramatically improve the capacity for providing complex health care in any community.
Hi, Manuel.
How's it going?
Good. How you doing?
Here's how ECHO works. In communities where specialists are in short supply, whether a rural New Mexico village or remote Army base, primary care providers like family doctors, physician assistants, and nurse practitioners learn to fill the void. They do this by consulting with and receiving didactic training from specialists in large medical hubs like the UNM Health Sciences Center, and they do this via secure video link.
And it is the teach a man to fish rather than hand him a fish mentality that allows us to build champions, build capacity in our remote areas.
We tend to get a better response of depression from 90 to 120 milligrams.
But first, the ECHO model needed to be adapted for use in military medicine. Teams representing UNM and Army medicine work together to develop a deliberate and standardized approach to implementing ECHO telementoring hubs across multiple Army sites.
We're all here housed in the same area. And
part of that approach begins with boot camp, ECHO Boot Camp. Army medical professionals visit the UNM Pain Center either in person or virtually through video teleconferencing, where they learn in part through mock ECHO clinics techniques on how to effectively communicate, consult, and mentor primary care providers.
So what was the concern about the immune modulating agent?
Army Regional Medical Commands then stand up their own hub, where they are first mentored by the UNM ECHO team before eventually conducting clinics on their own.
We weren't really teaching these clinicians how to treat patients with pain because they know how to do that. We are training them how to communicate with their partners.
But for Major Jeff Teedy, chairman of the Department of Pain Management at the Eisenhower Army Medical Center, ECHO is much more than a communications channel. It's about bringing a team approach to complex pain cases.
So it is much more critical than just PR or education. It is truly co-management. And that's our model, and that's truly what we try to do.
Count Colonel Craig Page a believer.
Well, did they rescan you?
Yes, sir.
He's a physician assistant at Fort Benning, Georgia, where he was asked to provide pain care.
Through UNM Project ECHO and CERMC Project ECHO, the didactics from both forums, I have come a long way in my ability to take care of and manage patients that suffer chronic pain and acute pain.
Each week, the Army now has multiple pain ECHO sites, providing didactic training, awarding continuing medical education credit, and improving the confidence and competencies of military primary care providers around the world. For ECHO founder Dr. Arora, the collaboration shows how this program can be applied to health systems far beyond New Mexico's borders.
Wherever there is a central body that is taking care of patients which are widely distributed in a country or different parts of the world, Project ECHO can be used to bring better health care in a more cost-effective way.
Great, interesting stuff. I just want to emphasize again that the ECHO model is built on 4 things. It's built on leveraging technology, promoting best practices, measuring outcomes, and case-based learning. So I've been a recipient of some ECHO training, and I thought that it might be helpful to tell my personal story about how I'm involved with telemedicine and technology, and how ECHO what it means to me and why I'm involved with the project. I want to thank you all for coming out. Thanks to Deborah and Ann and Kelly and AHEC and the Sheraton for hosting the program. My name is Daniel Saltman. I hope my talk communicates my appreciation for the generous mentorship that I've received over the years, and why ECHO Hawaii will be such a valuable resource here. I have nothing to disclose, except that I am on the steering committee for trying to develop the project in Hawaii, and so I have every hope that it succeeds and grows in Hawaii. For 14 years, from 1997, I worked at Kali'ipalama Health Center. I practice general internal medicine and see a lot of folks with diabetes and hypertension and high cholesterol, atherosclerotic disease, and the usual chronic and acute conditions of primary care. During those early years in the mid-'90s and late '90s, we networked together computers that we got and hooked them up to the internet with a T1 line that AHEC had donated to the Community Health Center. The federally qualified health centers, the FQHCs that you've heard some about, also known as CHCs, the Community Health Centers, they all received Weinberg grants for telemedicine around that time. So we hooked up our machines and attended the weekly Tuesday grand rounds at the Department of Medicine using video teleconferencing over the Stan Bridge, which was in its infancy. Not all the providers at Kali'ipalama had computers in their rooms, so I wrote a National Library of Medicine grant to get computers for everybody and to train the providers on library searches and information management. Kali'ipalama hosted a Hawaii website, a Hawaii local site using video conferencing to participate in a live national health and human services teleconference about ending health disparities. At that time, the University of Hawaii telemedicine project was ramping up, and Dr. Richard Friedman was the director of that. He mentored me at that time to be the clinical director for the program, and the goal of that project was to produce an online curriculum in telemedicine. He was a flexible and creative mentor, and he encouraged me to develop clinical projects that would inform the curriculum. Dr. Dan Alicata, a psychiatrist, and I worked together on a telepsychiatry initiative in the public schools that was a predecessor to what you heard in the earlier talk today from Dr. Roth. We produced a folder of practical documents for implementing telemedicine, and we presented our work at some meetings in 2003. 5 years ago, I moved to the Waikiki Health Center, and there I met Dr. Alan Tice. Dr. Alan Tice was an infectious disease doctor who I'd already known from Kali'ipalama because he worked all over the place, and he was energetic and engaging character. He sponsored my American College of Physicians Fellowship, and he was a statewide expert on MRSA. He held conferences on methicillin-resistant staph, and he was an expert in viral hepatitis, among many other things. He was retiring from clinical practice, and he endorsed me at Waikiki to take over his hepatitis patients that he had been treating. And at that time, the treatment was quite difficult with pegylated interferon and ribavirin, and I'd had a little bit of training in how to take care of hepatitis, but I jumped in and I inherited 3 or 4 patients on treatment after he retired. So I found myself among the relatively few in town that were treating those folks, and I had to learn fast what were the best practices and what were the right practical methods for how to do that. Dr. Naoki Sai, a hepatologist who was head of the St. Francis Liver Center at the time, who's now head of the Queens Liver Center, was also a generous and terrific mentor for me. He has an amazing fund of knowledge, And he's consistently reached out to clinicians all over the state, anybody interested in treating viral hepatitis B or C, to help them understand best practices and the underlying science and research behind hepatitis care. He mentored me and continues to mentor me to improve my understanding of viral hepatitis and liver diseases in general. So in early 2012, in my rush to get up to speed about how to treat hepatitis, I found a terrific resource, Project ECHO. Dr. Aurora and his Project ECHO had put together a hepatitis C teleclinic, one of these clinics that you just saw a picture of, with many of the biggest names in hepatology in the United States. And I don't know if it shows in this slide, but these are the heads of liver centers all over the country. Michael Fried, Robert Gish, Bruce Bacon, Paul Kuo. These guys are they all run big research projects in hepatitis, and they were the expert faculty that I was participating with and heard case presentations from a number of other people. So I was fortunate to be able to participate over my lunch hour using a desktop video conferencing, and I was impressed with how easy it was to schedule, the quality of the short didactic presentations, the case presentations that other people presented that I got to learn from, and the opportunity to interact with these experts and ask questions just from sitting at my computer at work. So I learned a lot about the art of hepatitis C treatment from these clinical leaders. So in assuming Dr. Tice's hepatitis practice, I also inherited the course directorship for an annual viral hepatitis Hawaii conference that was held. And not knowing any better, I reached out to some of these big names that I had encountered in the hepatitis world to come to Hawaii and present for this conference. And guess what? For the viral hepatitis update in 2012, the master researcher, clinician, and teacher David Bernstein showed up. And he gave a great talk that was well received. And also, another national expert quoted at all the liver meetings and in the Wall Street Journal, and a brilliant researcher, Paul Kuo, came and talked too. So I invited Dr. Aurora at this time too, who was the head of the ECHO project, and he couldn't come. But guess what? The following year, he showed up. In 2013, he presented a great talk on Project ECHO at that conference. And he was very well received. And afterwards, clinicians and students all came up and wanted to know how they could participate with the Project ECHO. And I was inspired to join in and try to bring this to Hawaii too. Dr. Aurora has become a mentor for programs all over the country to develop the specialty skills in underserved areas. He believes in democratizing knowledge. He's committed to a vision of quality improvement among primary care providers on the front lines. And he's generously supported the efforts to build an ECHO Hawaii project, replication of their Project ECHO here. So I've also been most fortunate to be welcomed into a talented team of people who share that vision and who want to help those in need in rural Hawaii. And even though the road is long, the rewards at the end are great. So ECHO Hawaii is an innovation in postgraduate medical education through the use of case-based learning, which is usually an undergraduate medical education technique, but for this, it is in the postgraduate world. And it's about being a part of learning communities and receiving mentorship from great clinicians and teachers. It's also an innovation in that it develops capacity for specialty care among primary care providers. And as primary care providers build their skills, they'll create centers of excellence around the state. So that's what Project ECHO means to me and why you should consider joining us in moving this forward. Thank you very much. And Chip Chips.
Hi. My job is to be the closer. So I won't take the 10 minutes that was allotted to me, but I'm going to tell you a few things. Echo Hawaii is very soon to be reality in our community, in our rural communities. We do currently know just about everything we need to know to make it reality. We have a viable, proven method to fulfill the needs of our rural docs, of our other health professionals, practitioners, and our communities. Most importantly, our communities. This is a program that is existing in 54 localities, 54 localities, many of which have more than one echo clinic a week in 10 different countries. Currently, we have just a little bit over half of the money we need. That's a biggie, because it's a substantial amount of money that needs to be secured before we can actually start. And we have a really dedicated team. This is in Hawaii for Hawaii. Hawaii State Rural Health Association, AHAC, Department of Health of the State of Hawaii, Pacific Basin Telehealth Resource Center, and Ohana Health Plan, at whom I am employed. It's simple to use. This is existing technology. Your computer sitting on your desk has just about everything you could possibly use to get this right now. It's a sharing of best practices. It's communal learning. It's web-based database to monitor outcomes. It builds community. I'm a community advocate. That's what I get paid for. This really builds community, and particularly for isolated health practitioners who maybe don't have the ability to bond with, make friendships with their peers. This will help that. That's the one I didn't want. So what does it do? Otherwise, what does it do for rural health clinicians? No-cost CMEs and nursing CEUs. Free. Faster treatment for your patients. Dr. Aurora talks about how it took months when he started this for somebody from rural New Mexico to come to see him. That's why he was seeing them at such a late state in their disease process. So it's faster treatment, professional interaction with colleagues who all have a similar interest, less isolation, which we're hoping will equal improved recruitment and retention of healthcare, of docs and other healthcare workers. It's a mix of work and learning. And it provides the access to specialty consultations on an absolute every week basis. So, how can you be a part of this? Very simple. There's plenty to do. Tell us how you can benefit from this, how we can help this process benefit your practice. Share the message. I have pen and paper up here. If you'd like to sign up, if you want to be consider being a spoke, or if you live in Honolulu, you'd like to become part of the team, let us know. We will have an echo starting, God willing, first week of January, and it probably will be one of two different disciplines, either behavioral health or endocrinology. But whichever one it is, the other we will have up during the second quarter. So this is happening fast, it's happening now, and it's happening here. Please. We're really kind of excited about this, you can tell. Please, if you are interested, come sign up, ask questions, let's get this thing done. Thank you.
So yeah, we'd like to open up the floor for any questions people might have. We have plenty of time to answer anything you might want to ask about ECHO.
Kelly's been preparing me about ECHO, and I'm really glad that you came today to tell us more about it. It's a very exciting project, and I guess my question is more of the nuts and bolts. I saw that you said you could get CMEs and CEUs. So then what I don't quite grasp yet and would like, and then you mentioned a lot about hepatitis and liver, is there a set curriculum? How does the exchange of information go on? And is it only about hepatitis, or is it about other diseases? Because the leader is a hepatitis specialist, but I'd like to know more about the nuts and bolts.
What happens is we have what are called Echo clinics. Each clinic is a particular discipline or specialty or disease state that is focused upon. As Ann mentioned, we right now are currently setting up 2 teleecho clinics. One is for endocrinology, okay? The other one is for behavioral health. One of them will start in January. The second one will start in the second quarter. All right. At some future date, we do plan on adding additional clinics that will focus on additional disease states and on different specialties. But each teleecho clinic, okay, has one particular focus, okay? They meet for a period of 12 weeks. Pardon me?
It can be open-ended and ongoing. It doesn't have to be.
Typically it's 12 weeks, okay? And typically the meetings are for an hour and a half. They try to schedule them at a convenient time, such as at noon, so that it's over people's lunch hours. There is typically, and again this changes too, a 15-minute didactic, okay, that has to do with a particular discipline or disease state that is under consideration, okay? And that rotates, it evolves, it can be topics of current interest, okay? And then following that 15-minute didactic, then participants who have agreed ahead of time will present case studies, okay, of actually their particular patients. The case studies, everything is done ahead of time. You know, there's a form that has to be filled out with all the information about the case, so forth and so on, so that the hub site doesn't see this cold. They have seen this ahead of time. Then what happens is during that remaining 45 minutes, half an hour, whatever is left in the period of the time for the clinic, okay, there's a teaching, if you will, between, okay, the hub site and the participants. Okay, does that? Okay. You're going to add to that? No?
It really is a consultative process. All these cases come in totally de-identified, so there's no HIPAA or PHI issues here. The presenter gives the basic information and the nature of the problem, and then it is the specialist discusses what his or her recommendations might be, and everyone, if they choose, of the colleagues at the spokes also get in to give their opinions, and ultimately the practitioner who brought this issue to the floor has the option of following their opinion or doing whatever he or she feels is the most appropriate thing under the circumstances. And that individual is the one who really sees the patient face to face.
Thanks. My name is Wes Sugay. I'm a pediatrician on the Big Island. I've noticed a lot of my colleagues from the Outer Islands here at this conference today, so this is very important for us. There's a couple things. One is sometimes we can't make it to a certain specified time. Say I get called out for a C-section and I wanted to be at this conference or this ECHO conference and I can't make it. Is it is it going to be archived somewhere that we can retrieve it later on? And second question is, number two is, rather than reinventing the wheel over and over again, there's a lot of other echo things like in New Mexico or Arizona where Dr. Aurora is. Can we hook up with them? And are those archived too?
Yes, the simple answer to both of those is yes. One of the main benefits of ECHO is not a seminar, passive learning arrangement that you would sit and view the archives. One of the main benefits is active case-based learning, where you bring your difficult cases, de-identified as they say, and present them, and so do other clinicians at the same time. And as the expert hub reviews those cases, everybody who's participating learns from the discussions. They are not. So many times these are open-ended sessions as well. So we viewed a hepatitis one where the presenting spoke sites, the clinicians in the community, and these can be their physicians, their advanced practice nurses, their physician assistants, anybody in primary care basically. Some of them had been doing this for years, and they had a long-term relationship with the hepatitis team. That's just hepatitis. And so these different topics, this is sort of an answer to your question also. So these different topics might get started, and they can be ongoing for a long period of time with some changes in the personnel, both at the hubs and at the spokes, but that the topic continues on. And that answers your question of whether if you miss one participation this time, that's okay. You can come in the next week and participate again. Sometimes the experts put together a curriculum cycle. That might be where some of the 12-week idea comes from. So they might present these short didactics at the beginning of each session and go through a curriculum cycle. I can tell you for the hepatitis one that I participated, I think they had a 5-week cycle. It was an unusual thing. 5-week cycle, and if you missed it the first week, they repeated it, and you could get it again. I mean, the first month, you could get it the next month and see it again.
And Kelly, just one more thing. The rural physicians always have a hard time with CMEs. We don't have any grand rounds. We don't have any Monday noon conference.
This would be 1.5 hours a week.
Yes. Is it possible to somehow hook that, maybe off topic, I'm sorry, but to get something like this to the Outer Island physicians?
This is designed for you.
In grand rounds.
Oh, grand rounds.
Hook up grand rounds, infectious disease rounds in our specialty areas that we are so in need of.
Okay, so infectious disease. So if that's a big need for your docs and providers, we could have an ECHO clinic on infectious disease. And that could be the topic that we do for 12 weeks or more for an hour and a half a week. So we would find you the hub team and maybe some on Maui even, and then you would connect up. But maybe if Queens likes this system so much or anything, they would do grand rounds using this technology, which is free. So, hopefully.
Hi, I'm Aida Wen with the Department of Geriatrics at UH. I had a question. So, just thinking from our viewpoint of trying to, share geriatrics and help primary care providers across the country, like, who are the faculty? And how are they reimbursed? And, logistics like that.
Good question. So the faculty are any willing and able and ready experts who are prepared to take this on as we're looking to put together expert teams and hub teams. So if there's a special interest in being a hub team member and you want to try to bring this out to primary care providers, then we want to talk to you. But the reimbursement is one of the expenses of the project itself. So there's a payment for the 2 hours a week of your salary. That's the general model.
So we would recruit experts. They tell us that we should recruit the winners of teaching awards. Well, we don't have very many teaching awards in Hawaii, so it's hard to identify those people. So what we're doing in behavioral health and endocrine is we're contacting people who we think are good teachers, and we're actually meeting with them by on the internet and seeing if they would work, and then the pay would be structured such that each of the experts would get 5% of their time paid, as that's what it's estimated from New Mexico to do, and then whoever is the physician coordinator of that clinic runs it, recruits the CME, the 15-minute speaker for each session gets 20%. So that's how they've costed it out for us, and so that's what we expect we'll do.
Hi, I'm Teresa Wee. I'm a pediatrician in Waipahu. One of my concerns, I don't know if they have this in New Mexico. My passion is pediatric obesity, and pediatricians from outer islands have been asking me to come out and reach out to them, and I think the idea of this is much better to train other people to go out and reach out. And I'm actually have several Molokai trips. They don't have a pediatrician in Molokai, but I'm just thinking that do people ever do more prevention type things? I mean, right now we're talking a lot about disease, but I know that for a fact, everyone talks to us about pediatricians have responsibility to work on the younger generation, and so I think it's really crucial to teach, and after over 31 years of practice, I feel like I have information, and rather than have our younger folks kind of go through the whole thing, I'd like to share, different parenting, how to teach parenting skills, how to reinforce things that will prevent obesity. But has that been done in New Mexico more for prevention rather than disease states?
Well, again, ECHO is not particularly a seminar idea. It's not like going to a lecture and having somebody teach in a lecture mode. It's about case-based learning is one of the essential things that makes it ECHO. But saying that, there's no topic that's off limits for this too. The topics that tend to lend themselves to ECHO projects are ones that involve complex decision-making in both diagnosis and treatment. And certainly childhood obesity might have pretty complex decision-making and treatment decisions, and perhaps in diagnosis too, I don't know. Yeah. But those are the topics that tend to have success or have longevity in the ECHO world. So the things that have been successful: HIV care, the endocrine clinics, hepatitis care, psychiatry, pain and palliative care. I think there's some geriatrics models. There's what else? Addiction medicine.
There's infectious disease.
Infectious disease is a good one. Yeah, there's no limit on it exactly. When we went and trained there was a woman who was trying to do an educational model to train people in refugee camps to do educational things. So it's got applicability outside of medicine even as well.
And the medical examiner.
Oh, the medical examiner's office at the university in New Mexico, at the state of New Mexico, was there training their caseworkers. They wanted to have the caseworkers present cases, and they would mentor them to become better investigators in the medical examiner's office. That was a good one.
I'm going to pass out the pieces of paper, and if you want more information on it, just put your email on it. And if you have a specific topic that you want covered, like infectious disease or childhood obesity, put that on it too, okay? But go ahead, ask your question.
My name is Hun Park. I'm a pediatrician too, from Kona now. I used to practice in Hilo for 31 years. My real question is, what equipment or what facilities do I have to have it to connect with this in a hub?
Good. Well, I know I'm hogging the thing. I just want to say that Zoom will work all the way down to 3G on a phone and all the way up to dedicated video conferencing equipment?
Basically, at the spoke sites, you need either a computer with a webcam or a laptop or a tablet. Just anything that you could, even a phone, although, I mean, a phone really is probably, you probably don't want to go that small. And in terms of the software that we're using, Zoom, it's an interactive, real-time, point-to-point, cloud-based video teleconferencing system. It's very easy. The meetings are scheduled. You're sent a link. You click on the link, and you join the meeting. I mean, it's so simple. I mean, it's hard to get messed up. The thing is that we've also considered that there could possibly be participants who would be interested in participating as a remote site. And right now we are investigating the possibility of the project acquiring laptop, tablet, whatever that could be given out as a loaner. And we're also looking at ways to see if, in fact, internet connectivity is an issue, whether there's something that we can do about that. So we are addressing that as well. But there's always a hook. The thing is, if you take a loaner, then you have to apply for the FCC Healthcare Connect Fund so that you can acquire your own equipment and your own internet connections, okay, at greatly reduced prices. So, right.
Basically, anything with a camera, an internet connection, and a microphone works with this platform.
Is there, I'm Colleen Noe from Maui, I'm a gynecologist. Is there a specific time during the day that you're only going to be doing the meetings?
You know, we expect that these will be scheduled, and it will depend on the expert hub sites and the spoke participants. So what, you know, the times that work out for everybody will be the times that they're scheduled, I expect. So it's not carved in stone, it's something that'll be scheduled.
And then for the people who are participating, like say, for example, the one that we participated, is it just going to be Hawaii physicians that are going to be probably participating during those particular meetings and doing it as far as, you know, I was just curious whether or not, do you join other physicians from other states, or is it usually just you're doing it locally?
You know, that's a good question, and that's related to an earlier question as well. There are, you know, there are some opportunities to participate in other ECHO clinics that are happening in other states, and you can see which ones of those are open by going to the University of New Mexico's website, and I think there's a place where you can see what other ECHO clinics are available. I think our goal here is to develop local capacity for this.
And then my last question was that to go ahead and roll this out, and I mean, we're here, we're learning about it. How were you going to inform the rest of the Hawaii, state of Hawaii, the physicians? I was just thinking that, you know, I might know other people on Maui who would like to be a part of it, but are not here to go ahead and know about it. So how would they go ahead and enroll?
We are currently working on a marketing plan that is going to do that. It's going to speak to everybody who can be involved.
And are the funds that are going to be running as far as this project, I mean, is it where, I mean, it's not where you're going to be able to do this just for a year or two, and then unfortunately it's not going to sustain itself, or is that...
Whether it's what's the economic model for sustainability?
Right. I mean, I hate to start it, and then of course
there's been out of the over 50 clinics that have been developed as replications of Project ECHO, none of them have closed down for a lack of money. They are sustained in a model that it is disruptive innovation. They're sustained in a model that is not a fee-for-service model. It's about multiple stakeholders. And so the ways that the programs in other places have been sustained is through a mosaic of stakeholders who contribute. So it's often state departments of health, insurance carriers, sometimes it's educational institutions. Who else? Oh, grant funded, that's right. Grant funding, federal funding, Robert Wood Johnson. There's I said state departments of health, other state funding besides departments of health even. So they're put together with a kind of mix of payers.
No, it sounds great. I just hate to see it start and then not be able to sustain.
Yeah, we feel the same way.
Maybe for the marketing, we should have people at least put down their emails if they're interested, so we can target, and then you can by all means get the word out from there. And then maybe also likely times that the clinicians are most likely to be able to participate. I think I'm sorry, I'm Liz Tam, and I'm part of Hawaii State Rural Health Association. I'm saying we're going to do this in January. The more information we can get from our stakeholders and our users, that would be really great. So tell us as much, and obviously there are a lot of topics you want covered. So, but I'm really glad we focused on behavioral health and endocrine, but our lunch speaker really pointed out the really driving need for behavioral health, especially in the 10 to 19-year-olds. You know, even though I'm in internal medicine, my clinics already are like psychopulmonology, you know, and I see a wave of young people coming up. So I think, thank you for doing this. Thank you.
Sure.
I'm Lani. I like to talk a lot for family nurse practitioners and mid-level providers. I am an SLRP awardee, so thank you, Kelly, because you guys know we do fill the gaps a lot in rural care. So I'm hoping this is going to be an inclusive rather than exclusive thing. Because we fill the gaps, I'm seeing a lot of sick people to help our docs see the more sicker people. But a lot of times I'm like, how am I going to deal with this? I do not have the education, and I feel really bad because I don't want my patient going away without getting the right answer. So please make sure to include us because we are doing a lot for our communities. Thank you.
It is by design a very inclusive model. Right, we appreciate that kind of work. And there are some clinics that are about community health worker training and skills development, as well as, like I say, any primary care provider, but the community health workers are part of that. We regard them as part of that as well. And it is the goal is to have as inclusive an approach. The New Mexico guys, a lot of the training is very much about video conferencing etiquette and how to facilitate those conferences so that people are included. It was really very, very positive, very, very broad. Yeah.
Thank you so much.
Thank you so much.